whether you're using that or a more advanced one. So, you know, as we look down the future and expect these to expire, we need to start thinking about investing more in getting higher quantities in place.
Yeah, it would be scary if one would assume that there was going to be no replenishment of that equipment. That's a pretty strange assumption to make.
Dr. Carson, you had a thought on this one?
Yes. Well, first of all, I do not agree about the travel ban. The person who came in here who infected 2 nurses would not have come in here if we had that travel ban. So I think there's something to be learned from that. I think either a travel ban or quarantine, I think there's compromise that can be had there. But
are you proposing then that, would you say that a travel ban from the 3 most affected Western African countries should be in place?
A travel ban or some type of quarantine system. There's just no way, for instance, we should have an instance where this doctor came in here and is roaming around freely in the public. That should not happen.
I want to, if I could respond to that, I'm glad to hear Dr. Carson talk about compromise. That's good. Monitoring and quarantines, you know, various permutations of quarantine are the way to go. An absolute travel ban might have prevented Mr. Duncan from coming into the country, but I guarantee you it just sends everybody underground, and as we were saying, it prevents the brave men and women, for example, of organizations like Médecins Sans Frontières from getting to the affected countries, which is where we must win this battle.
And as you mentioned fear and where we have to win the battle being Africa, Nelson, you brought up the idea of fear earlier, and what we're seeing in Africa, specifically with families in those 3 countries, when one of them does become ill, they don't go for help because they fear it's a death sentence.
That's right.
And when they don't go for help and they stay in the home, the infection becomes larger, the circle of people who are affected becomes larger. So fear obviously can hurt the cause as well as make it a longer lasting effect, right? What were you going to say, Nelson?
Well, Dr. Carson touched on this in his earlier comment about lessons from the past. If you remember in the early days of the HIV epidemic, testing was done anonymously. Testing was done anonymously because we knew that if you didn't do it that way,
they wouldn't get tested.
The stigma attached to the disease, in part because of the populations that were being affected at the time, would result in people not being tested and and the spread being increased. So I think we want to encourage people to to come in and get tested. I mean, the doctor in New York, I think, did all the right things. Okay, he came back. He was asymptomatic. Okay, but he watched himself very, very closely. At the very first sign of a symptom, he picked up the telephone.
But a lot of people would argue that he didn't, and they're going to say it's because even though he was asymptomatic, even though he didn't show signs, they would say, out of an abundance of precaution, maybe you don't get on a subway, maybe you don't go bowling.
Well, you know what? A lot of people are going to say a lot of things, and they're going to continue saying those things because of the mixed message they're getting. I mean, you said earlier, should we quarantine? Well, I don't know. I mean, I can tell you what people were saying 2 hours ago. And the administration was not saying the same thing that the military was saying, and the governors of New York and New Jersey were saying something different from both.
A lot of people on a lot of different pages
now
right
changed
now cause a
it.
problem.
The governors of Maryland and Virginia are now saying something different than what those 2 guys are saying. And at some point, I mean, you can understand why the public is going crazy.
And again, we have to remember about transmission. We do know a fair amount about transmission of Ebola. This disease has been around since at least 1976. You're not going to catch it because somebody's riding on a subway necessarily. I mean, the 2 nurses in Dallas who did get it were in inadequate protective gear
and dealing with the worst
dealing with bodily fluids
of
from a
which
man
was.
dying
Yeah,
of
he
the
was at
disease.
his absolute worst. But it doesn't change the fact
that transmission increases as the severity of illness increases.
Right.
So when you just have a fever, your transmission capability is much different than if you're severely ill.
But because, and we're going to go to Kai Jackson in the social media center here in just a second, but the reason there is that fear of perhaps I could get it on a subway, the reason that exists is because we have had mixed messages. So people didn't inherently trust trust what was being said either by the government or the CDC or NIH or a local hospital. And so there were question marks by people who were either skeptical, cynical, uneducated, or frankly just didn't know if the government had its act together, and therefore are doubtful. And that's reasonable that they would have those doubts.
And I want to just say, I agree with that. I think people who have been from the affected areas, even if they're symptom-free, should use great social caution to limit anybody's exposure for some period of time until they know that not only are they asymptomatic, they're free of the virus. I think that makes good common sense in terms of social responsibility.
Kai Jackson?
Yes, Scott, our doctors literally have not had a break here. They're two infectious disease experts, and we're really pleased to have them here and appreciate their service tonight. A couple of good questions coming in on the phone banks. The phones have constantly been ringing. One person asked about experimental therapies and dealing with Ebola, whether those were out or not. The doctors are trying to answer those questions. Here's a question that came in. A mother called in about her adult daughter who works in an area health department, and she's nursing. That daughter who works in the health department, she's a nurse, just had a baby. She wanted to know whether or not that daughter might be putting her child at risk because she's nursing her baby. That's a question perhaps our panelists can answer for us, Scott. Let's go back over to social media for a second, too, because we have another good question that someone posed on social media on Twitter. Is the 21-day waiting period, long enough for a person to be able to determine whether or not they have the Ebola virus? Scott, let's go back to you and see if our panelists can answer the question about the nursing mother and this question about the 21-day period in terms of whether it's long enough. Scott?
All right, thanks, Kai. I don't know if anyone knows the answer on the nursing mother. Doctor?
And don't forget sex. We were asked about sex too, Scott.
Remember, all body fluids can be transmitted with all body fluids. Breast milk you can find the virus in breast milk, so you can transmit it from mother to child.
And intercourse?
All body fluids.
Right. Easy answers on those. The 21-day quarantine, that's maybe a different debate to have, because some people are wondering if 21 days is long enough. I know that one of the Dallas nurses who was very, very closely taking care of Thomas Eric Duncan is beyond her 21 days, but is still very closely monitoring herself every day and having someone take the temp every day.
But that nurse is the 21-day period that she is currently monitoring is not because of her exposure to Duncan,
it's for the nurses, Amber Benson, and
to the earlier nurse.
To the other nurse.
Sure, but is the 21 days sufficient? Do we feel confident in that 21 days?
I do. The CDC is pretty firm about this, and the 21-day mark is something that we have to have a standard, and that's it.
Let's go down to Rajani Ward in the newsroom one more time, because you represent all these nurses who obviously have concerns. My question for you is this. If you know that there is the potential of going to Africa, treating people, coming back, and even if you didn't show symptoms, that you might face a 21-day quarantine instituted by whatever state you might live in, would you still go? You as a nurse, would you still go to these countries knowing that you might come back, be perfectly fine, and still face a quarantine? Would that deter you?
Me personally, I can't speak for other nurses, but I would say no, that would not deter me, because, as a nurse, we're dedicated to our patients, and I'm dedicated to all patients. And, if I volunteer to go to Western Africa, I do that because I want to take care of those people, and what happens to me on the other side is not a deterrent at all, personally.
All right, well, health officials continue to obviously keep a very straight focus on educating people that Ebola is spread only through bodily fluids. But many people, as we've discussed, are skeptical. And we took one question about this from Texas.
My name is Anthony, and my question is, can Ebola go airborne?
A lot of people are asking it. I know the answer over and over is no, but is there any possibility that we've got this one wrong and that it could mutate into an airborne virus?
Any virus can mutate in time. So can it happen? Yes. Has it happened? There's no documented evidence of an airborne recipient of Ebola.
I think that's really an important point. Any virus can mutate, and they do historically. Look at the great influenza epidemic of 1917, 1918. Initially, it started out as a non-lethal infection. You came down with cold-like symptoms, but there were no real mortality rates initially. It mutated in an army camp in Kansas and became lethal, and became one of the, since the Black Death became one of the great, killers of humanity, in the epidemic of 1917, 1918. There is no evidence, as Scott says, that I'm aware of, since 1976, because we had a lot of experience with Ebola, not here, thank God, but in the affected areas. There is no evidence whatsoever of it being airborne, or that you could contract it by any other means than exposure to bodily fluids.
This is what I love about Congressman Connolly, because he's basically a walking encyclopedia and history book at the same time. But I have a follow-up for you, because in your testimony and in your prepared remarks the other day, you said that we are, quote, astonishingly unprepared. And you weren't just talking about Ebola, you were talking about everything from SARS to smallpox. This nation is getting a wake-up call right now that we need to be prepared for the next bigger and badder thing, aren't we?
Yes, and the context of that is, I believe we need to be doubling down on our public health investments. As chairman of my county, I saw it in terms of getting ready for pandemics. I saw it in emergency preparedness. I saw the weaknesses and the strength in the system. I saw it after anthrax attacks. This area was, seriously affected by anthrax attacks. We had 2 or 3 deaths because of exposure to anthrax, and we were woefully unprepared as a country for that. It's just not something we had prepared for. And so we need to double down on protecting the public through public health investments.
Let's go to Dr. Ben Carson again, because my question for you is this, Doctor. I know that this is not your specific field of science. You're a neurosurgeon, but at the same time, you spent a lot of years at a very established, we can say at the very least, institution of Johns Hopkins, and you have seen over the decades the way that we prepare, or in some cases are ill-prepared. Were we ill-prepared for this, and are we going to be able to evolve quickly enough as a healthcare system to handle this in a matter of months, not years?
Well, first of all, before I say that, I should mention that we've known about Ebola for almost 4 decades, and we didn't have this kind of a problem with it. So to some extent, that may indicate that it's already undergone some degree of mutation, not into an airborne form, but into a more virulent form. And we must be prepared for things that we are not expecting to occur with this virus. How prepared are we? One thing that's been very encouraging to me is seeing that we do have the ability to evolve. One of the problems is that sometimes people get cocky and they try to defend their position and they won't move. And I am seeing some degree of movement here, so this is actually very encouraging. But I'm very frightened that we're not going to take it seriously enough in Africa. This is where I'm really concerned, because if it continues to increase there, it goes across the continent, gets into the Middle East, where the hygiene issues and the crowding is quite a problem. I could see a lot of bad things happening, so we really need to concentrate our efforts on stamping it out fairly quickly and working on the vaccine. I know there's a lot of work going on with the vaccine, and we're extremely good with that, and I think we will come up with something. It's a race against time right now.
Yeah, Doctor, thank you for that perspective. And 2 things that brings up, I believe, for our panelists here. One is both Texas nurses, one cured, one very close to the road to recovery, they say, are getting better. Are we getting it right? Is the system we're using right now, and I know it's a complicated system of using blood that's been treated and, from cured patients and introducing it to those who are ill, is helping? Are we close to getting it right? And secondly, let's point out the fact that the reason there isn't a vaccine is because what pharmaceutical company is going to jump on this measure when they know they've got a handful of cases in the United States, and are they going to spend hundreds of millions, if not billions of dollars to produce a medicine that might not go into widespread use here in the U.S.? Who wants to tackle that one?
I'll let the congressman get that.
Let's deal with that issue that you just put your finger on. That's not only true here. That's true. That was true in the treatment of HIV in overseas, and it is true in terms of resistant bacterial strains resistant to antibiotics. There is not a single private pharmaceutical firm left in the United States doing basic research on new antibiotics. Not one. And
but
so
it all comes down to dollars and cents.
Dollars and cents. It's not profitable. So what could go wrong if we now have broad-scale resistance to antibiotics in the general population? Well, common infections that we haven't seen deaths from in generations could once again be quite lethal. And so it's up to the federal government, unfortunately, but it's up to the federal government to provide this research and development, and on a crash basis, in the case of Ebola, try to develop a vaccine that is efficacious.
Doctor, how important is it and how significant is it that these two nurses are doing much better based on the treatment we've brought in?
You know, I think that the fact that they got early intervention, early electrolyte therapy, IV therapy, and treatment certainly helped. I don't know, you know, the viral load that they had or experienced, or they actually I hadn't been following the cases that closely to better know whether or not how sick they actually had gotten in comparison to the first person, the index case. So I think we need to take that into account, but I do know that early therapy does reduce overall mortality.
Like many things, early diagnosis is key in so many cases. Let's go to Kai Jackson again in the Social Media Center. Kai?
That's right, Scott. We've still have questions coming in through the phone bank as well as social media. We want to encourage people to call in 703-647-1533. Again, 703-647-1533. Don't forget, you can tweet us as well. Hashtag your voice, your future, so that you can pose in your questions, your comments about Ebola. Let's go to this particular question, Scott, and I'm hoping that our panel of experts can answer this question. Is it safe to leave it up to hospitals that are focused on profits, that's this person's viewpoint, to decide which CDC guidelines to follow? Scott, back to you and our panel of experts.
You helped run a state here. Is it safe to leave it up into the
I
hands
helped
of
run the
hospitals?
state. I was also an executive vice president
At HHS.
The University of Maryland Medical System and the hospitals there. And look, the fact of the matter is that compliance with these guidelines is not an option by the
Exactly.
hospitals. Okay,
Yeah.
I mean, the state licensing boards require that they do it. Their accreditation by the Joint Commission mandates that they follow these guidelines. So these guidelines are not optional guidelines. Hospitals generally want to do the right thing, and they're going to comply.
Let's talk about the flu. Let's give me some perspective on this, because a lot of people will say statistically you could just look at what we've seen with the flu over the years and compare it to Ebola. Now I know that's an apples and oranges to some degree, because the severity of the fear factor that's attached to Ebola will, regardless of statistics, create a bit of panic in people.
Right, right.
But doctor, the flu has done more damage than Ebola ever will in this country, you believe?
True, but I think we need to really understand that what we're saying here is that Ebola kills indiscriminately, regardless of your past medical history or predisposing factors. It kills indiscriminately. The flu, if you're going to die from the flu or have a mortality from the flu, you're more likely to have predisposing factors, diabetes, long-standing hypertension, be elderly, be bedridden, and those are the people that generally die from the flu. So Ebola kills indiscriminately, and I think we need to make that distinction.
Although it is interesting to note, in the 1917-1918 influenza epidemic, it actually didn't affect those populations as much as it did healthy populations. So if you were doing triage then, it was the obverse of today. It wasn't immune-compromised older populations. It was healthy young populations who succumbed the fastest and were the most vulnerable, because the antibody systems reacted so strongly to this new foreign entity that they actually, in trying to save the patient, killed the patient.
As we mentioned, we've talked with a lot of people about Ebola, got their thoughts, and this one kind of summarizes a lot of what we heard.
Two questions I would have is, are we convinced that all of the really painful screening at airports is actually making a difference? And just if you live in a busy city or you travel a bunch like I do, what should you do to just keep yourself safe?
How confident are we in what's taking place at the airports?
I think the screening procedures are doing their job. They're identifying patients that have fevers and have symptoms. And I think that's important in terms of the transmission capability.
People are going to say that what they saw, and this was early on, obviously, this is before we knew what we were dealing with, but people are going to say, well, Thomas Eric Duncan might not have been truthful about where he'd been or if he'd been around people who had directly had Ebola. So there's doubts in the system. Now, the system has changed a lot in those weeks.
Right, right.
But are you confident, Congressman, you oversee a lot of these committees that discuss things like the safety measures in place. Are you confident that what's happening at the airports is A, worthwhile and B, effective?
Well, you know, I guess I'm never going to be confident until something is foolproof and 100%. And that's what we're working toward. the protocols in place at our airports are filters. And I think, again, we have to remember, to the gentlelady's question, we're not talking about an infinite population that arrives every day in the United States. This is a very finite number. We know how many it is. It's about 150 at most per day. We know we can track where they're coming from because they're coming from third countries. And we can, as a first filter, check them out at airports, right? Ask them questions, look at symptoms, take temperatures, and ask for voluntary compliance in terms of monitoring if you've been to one of the affected areas. And more can be done, of course, once you get out of that system. Is that system working? By and large, so far, yes.
I think that there's no system that is going to be foolproof.
Exactly.
I mean, you're not going to.
But we want to move that direction.
But I think we should try to move in that direction. I also think that there is a certain deterrent effect to having those screenings in place. I mean,
How so?
I can't tell you what Mr. Duncan was thinking. And he obviously knew that he had been exposed to the virus, and he was at high risk. Yeah, he was not truthful when he came into this country. And now, if he'd have known that there were screening protocols in place, and that those things were going on, maybe he wouldn't have tried it. I don't know, but so I think there is the deterrent effect that makes these screening protocols worthwhile.
Can we talk about, and I want to bring Nurse Rajani Ward back into the conversation here, because as we mentioned flu earlier, there was an analysis done by someone not too long ago saying that if people don't get the flu shot and suddenly they experience flu-like symptoms, there will be panic among some. It may be a very small percentage of them, but they will show up at a hospital thinking they may have Ebola. The numbers will alternate. You'll have panic, or you'll have some people who remain calm. They might overlook symptoms that in theory could be worse. Are you worried about the number of people who are going to show up at the hospital during flu season now and say, do I have Ebola?
I mean, the reality of that is we want everyone to get your flu shot. That's important. But, I mean, if someone comes to the hospital with that concern, ideally they would be screened adequately, to take that seriously. So, I'm not worried about it, because hopefully the people that screen them when they come to the hospital, do an adequate screening. So,
Doctor, do you worry about flu season?
We're screening everybody that comes to the front door, or any registration point, any touch point within the hospital. You're getting screened in terms of where have you been in the last 21 days? Do you have symptoms of a temperature, fever? If that's the case, mask, isolate, and escalate the situation. And, it'd be nice not to have more people presenting with fever, but if you have to have fever plus to travel, right, at this point in time.
Yeah. It is a combination that's important. Let's go to Dr. Carson, and what I want from you, Dr. Carson, if you don't mind, is as we start to wrap things up here a tiny bit, is I want to know where you think we go forward from here. A lot of people are throwing around dates, and there's no deadline with this disease. There's no way to put a cap on when we're going to have it handled. But at the same time, do you think this is something that can be managed in a matter of months? And where are we on a scale of 1 to 10 progressing toward a goal?
Well, I tend to be an optimist because, the system that we have in this country is by far the best in the world, regardless of some of the other things that you've heard. And we will adjust in an appropriate way, assuming that we don't have, a large outbreak. I think we should take advantage of all this attention right now for viruses to educate people about the flu. Tens of thousands of people will die of the flu this year. Very few will die of Ebola. And if we can get people into the habit of washing their hands, using sanitizers, and taking the other precautions that we know, a lot of lives will be saved by doing that. But again, I would go back to what I said before about Ebola. The real focus needs to be in Africa. If we don't get it under control there, it doesn't matter how good our protocols are. We're going to be inundated.
All right, Dr. Carson, thanks so much. Real quickly, Kai Jackson in the Social Media Center. Kai.
Well, Scott, we want to thank our two doctors. They are infectious disease experts who have been answering questions all night about Ebola. Again, clearing up some of the myths, some of the fear. And again, they also agree one of the best ways to get rid of fear, to kill it like you kill a virus, is with science and with facts. But we've had Twitter comments coming in. We've had the phone bank lighting up all night. And again, it's not too late to voice your opinion about this. Hashtag your voice, your future. You can also call 703-647-1533 and pose your questions to our infectious disease experts. From the Social Media Center, I'm Kai Jackson. Scott, back to you.
All right, thank you, Kai. Gentlemen, let's go through some final thoughts here. Where do you feel your greatest level of confidence that we're on top of this, and where is your greatest concern? Doctor?
I think the hospitals are really ramping it up in terms of preparedness and the ability to care for these patients in a safe environment. I think that if you take a look at some of the construction that we've done and put in audiovisual cameras in these rooms to talk to the patients and have visual contact without having to go in the room, every 5 minutes. And I think that's a real differential that we didn't have that, a year ago or even a month ago. Mm-hmm. And unless you have to put hands on a patient, you're not going to be going into the room to care for that patient, but you'll have full audio-visual contact, and so will the family have that same contact that we have as healthcare providers. And again, my biggest concern is what's going on in Africa and the R value. It's doubling or tripling. I think we really, really need to watch that and take care of it there.
Nelson, what's your greatest reason to be confident here moving forward?
Well, I'm confident because I can see the way the hospital industry responds to things like this. And they respond quickly, and I think they've come a long way in a relatively very short period of time already. My biggest concern is that we seem to be forgetting that only a fraction of these possible people are going to be presenting themselves initially at hospital emergency rooms. We have other entry points into the healthcare system. And are we doing enough for the individual community-based physician office? What do they have in terms of protection? And what will they do? And what are they supposed to do? You've got neighborhood community health centers, health department clinics, the whole host of these other access points. CDC, or the CSC minute clinics.
Congressman, you've got your hands full, according to...
what are we doing about those points?
All these patients present generally now with, all physicians have electronic health records, and built into the electronic health record are the screening questions, regardless of your touch points. And assuming most physician offices, with meaningful use in the ONC, putting in electronic health records in the outpatient physician side, these screens are built in, and it's very important.
Congressman, your final thoughts here?
Well, I think after some missteps and after some glaring weaknesses in the whole system, we've come a long way, as Scott said, in terms of filters, in terms of prevention, early prevention, detection at airports, at portals for people to go to should they, in fact, be detected with symptoms. And I think Americans can feel more confident today than they could a few weeks ago even, that actually a lot of protocols and guidelines and systems are in place to protect this public. But at the end of the day, we must focus on West Africa. This battle is won or lost there.
Yeah, I think everyone tonight has agreed that Africa is where it has to not only end, but we have to recognize why it began and how to prevent it again. Gentlemen, thank you so much. Unfortunately, that is all the time we have for tonight. We'd like to thank our panelists here in the studio. Very educated evening here, who joined us from across the country as well. Thank you for tweeting your questions and joining in on this conversation. We appreciate it. It is not the last conversation we'll have on this topic, that is sure. I'm Scott Thuman. Good night, everyone.